ignore the fact that I have a microphone and I have a camera on me. And so we've done 3 hours today. It's your first time doing it. What questions do you have?
The first one is probably an easy one to answer, but sort of like what got you into osteopathic medicine? Like, as you described in your story, it's a profession that's kind of been buried and ignored, for lack of a better term. So, how did you find it? What got you into this?
Okay, I thought we were going to have osteopathic questions, but
We
we'll have
will.
a Dr. Starziak question. I got treated as a patient. I had bad back pain in 8th grade. I got into meditation and trying to sit still, just my back is just terrible. And it didn't get better. So I tried a lot of different things. I tried chiro, massage, acupuncture, and eventually got referred to an osteopath. And it just blew me away. Where most people, from where I sit now, I know this, like most people don't feel what's happening when it's happening. They'll just feel better afterwards. But there's a subsection, maybe like 5% of people, maybe 10% that'll feel a good amount of it, probably less than 5 that feel all the little nuance of what's happening and relate to it like on that level, and then they're generally very amazed. And so I was in that category, and I just kept getting, after I got better, I kept getting my dad to pay for treatments because it was so cool. It was like going and watching a master piano player or something, but like I was the piano in a certain sense. And I leave feeling so good. And it was actually the osteopath that I was seeing who suggested to me that I could do it. She's like, hey, you could do this if you want to. And she let me start shadowing with her in high school and actually treating patients hands-on. And so I started treating patients on my own, not formal patients, but just family, friends, whoever would let me in high school, and then through college as well. So by the time I got to med school, I was already really grounded in the indirect technique in a way that you can't really become grounded in medical school, because you're put into such an analytical framework that it's all about thinking, understanding, remembering. And this practice, you don't need thought in the same way. Understanding is different. It's not like a result of word-based thought. The thought that's happening when you're treating, it's like spatial awareness and awareness of sort of tactile realities that you don't relate to via a word. You relate directly to the reality, because as you balance it, that reality changes. It no longer feels the same way. And if you're not in relationship to it real time, but you're in relation to some idea, the process does not move forward. The gears do not mesh. And you're just like, what? Nothing's happening. And so you learn over time to relate directly to the phenomena with as little filter on it as possible. And so it really captured me, the practice, because doesn't that sound an awful lot like Zen? And didn't I say I started having back pain because I started practicing meditation? I got into Zen meditation. And I was too aggressive with my approach to full lotus, meaning like day one, I forced myself into full lotus. And I think I had some old injuries growing up, and I think I complicated them because I just ignored the pain and like forced it. So it's really cool. It brings together a lot of different disciplines, and you really need your full resources, because at other times you do need to think about stuff. Like when you're done treating, there's frequently things you need to figure out, and you need to be able to explain what happened to the patient and to understand it yourself. So the whole intellectual thing is needed as well. It's kind of like, two halves.
And then, sort of, my next question: when you are treating the patient, like, what are you feeling for? Like, what's your general like method of treating? Like, just like explain to me like what I just been witnessing.
Yeah. Well, and I'll summarize what I said. So maybe you're asking this question for the benefit of this, but it's also good to summarize, because you can probably hear this 20 times until you really get what it is. From my perspective, it seems like obvious. But we talked about Jenga, right? We start with that idea of the loose block of ease. When you're checking a Jenga tower, you're going to check which block is easy to move, and then you're going to move that block. So that's how treatment begins, is looking for ease. And the reason it begins that way, looking for ease, is because the lesions that are set up through injuries are not set up by something outside of us. They're related to something outside of us, the force. So there's this sort of unique imprint from the force. And then how does our body deal with that? Well, it doesn't just stay limp. It marshals a response. And so the lesion that gets set up is maintained by our system. So it's probably the central nervous system is involved maintaining it, bracing the fascia, bracing the ligaments. They have low levels of contractile elements, so they can be braced. So if we relate to it like it's a foreign thing and we try to destroy it or try to break it apart, you'll hear about people like breaking up scar tissue. Like, that's a really weird concept, because scar tissue comes when you cut something. So when the tissues are responding to a trauma through, like, they've expressed a lesion, that's not scar tissue. Like, you can get elements of contracture, like cross-linking of collagen, but you don't first start with breaking up those elements of contracture. Ideally, you start with releasing the central maintenance of it, right? So it's created by the mechanism, the lesion. And so we need to get the mechanism, the central aspect of it, to release the lesion. So if you fight that lesion, are you really in communication with the thing that set it up? No, you're saying whatever set this up is stupid. It shouldn't have set this up. I know how it should be. I know better. I'm going to step in and try to make it better. So usually with people who use that approach, you can shift things around, but usually you just keep shifting things around because it doesn't actually meet the problem. It's just, okay, yeah, my back got better, but now my neck really hurts. Something like that. So we start with ease because we acknowledge that the lesion is an expression of health. And instead of fighting with our own body's ability to heal itself, we want to work with it. So to feel ease, we have to pass through neutral. So we ourselves can't come with tension that's going to create an artifact in our ability to perceive. Like if you have, you want to measure anything, you want to eliminate background noise. So same thing with us. You don't want to bring like, I'm always doing this with my hands. So when I go and touch someone, I'm biased towards that. And so I don't feel the motions that do that. Like you want to be able to contact in the neutral position. And then from the neutral, then you can be more objective. And in the beginning, we'll motion test, where we'll actually introduce motion and feel for ease. But as you climb the ladder of subtlety, what does the motion testing is the inherent motion. So motion that you don't have to introduce, like you're breathing right now. That's an inherent motion that propagates throughout the whole body. There's an even deeper motion that we call primary respiration, which is slower than your average respiratory rate and which propagates throughout the whole body. So that inherent motion is present in there, and it's always working to integrate everything. When you get a lesion set up, it's like the normal tissue is folded in an origami pattern, or you have your Christmas lights are tangled up or whatever. The motion is still trying to get into there. And how do you get the motion into there? You disengage it, right? So you take it where it wants to go. So you decrease the tension on that lesioned part. And one way to look at it is it's like the osteopath is doing the lesion's job for it so that it can relax. Because you can't just tell it, don't do that anymore. It wants to achieve this goal. It's got tension to go back to a position. It's like time, it's like stamped by the trauma. This is the position. And now there's a gravity to that position. If you want to move on from that trauma, you have to go back and balance around that traumatic axis. And then when everything returns to normal around that traumatic axis, the axis disappears. But you have to balance it around the axis until the inherent forces return it back to normal. And then once it's returned to normal, cool, it's done. Like the magic has occurred. You can let the thing go. Like you'll feel it. The position that it pulls you into to balance will melt away underneath your hands. You'll no longer have a reason to be there anymore. It's like this was all a dream and now the tissues are fine. But when the stuff that usually gets to an osteopath's office though is heavy, dense, been around for decades. Because people don't know about osteopaths, even though we've been around since 1874 and we have been the source of multiple other things that people know about, like structural integration or Rolfing, chiropractics, cranial sacral therapy, orthobionomy, indirect myofascial release, direct myofascial release, all that stuff. But people don't know about it, so we end up seeing the folks who are at the end of their rope and who've seen all the king's horses and all the king's men. So usually these lesions are letting go of layers. So you don't get to the very center and get the whole thing to let go, because that would just be too much for someone to incorporate if they've been dealing with it for 20 years. So you get 20% off, and the next time you get 20%, you just kind of are peeling away layers and the symptoms lighten every time. Yeah. So yeah, that would be my approach, is indirect. You can get a little fancier and create distinctions. Like back in the day, we used to have direct, which is oppose the lesion, or indirect, which is work with the tension of the lesion. And those were the two big categories. And then there were tricks to use with indirect to try to speed things up. Now, I don't really use any tricks because I feel like that desire to speed things up, like where does that come from? Does that come from the health? Like, I don't think so. I don't want to obstruct anything. I don't want to slow anything down. I want to find, if I'm in the way, let me get out of the way. But it can kind of proceed at its own pace. It seems to go plenty fast. I do longer treatments though. I do hour treatments. So a lot of DOs end up actually having hands-on for 15 or 20 minutes, even if they're doing this as their full thing, because they'll do 30-minute treatments and then 5 minutes before they talk, and they finish up 5 minutes before the hour. And so, if you wanted to get more, draw more distinctions within indirect, you can. We have facilitated positional release and counter strain and positional release and still technique and articular ligamentous strain and balanced ligamentous tension. But they're all using the same principles. They're just doing it in a different way. It's kind of like different ways of shaking someone's hand, but you're still clasping their hand and shaking it, basically. And so, creating more distinctions and making things seem more separate doesn't seem to be very helpful to me. If you can see their commonality and you grasp it at the root, you grasp the principle at the root, then any situation that you face, you can meet it. If you focus on the ends of the branches and you kind of understand, okay, here's a particular technique for when someone has medial compartment wrist pain. Well, if you're relying upon that particular technique, it's not even going to work that well, because that thing's rooted in principles, and you have to be in this continual feedback cycle of listening and then doing something and listening to how what you did interacts with it. And if you can already do that, well, then all of the individual techniques will collapse into the core principle. If you can't do that, all of the individual techniques don't really work that well. So people who go around and collect techniques, they're just delaying grasping the principle. It's a fear that they won't be able to grasp the principle, or they haven't been able to, and they don't want to make their stand there. But if they collect enough techniques and they can just explain stuff in enough ways, then maybe that'll get them there. And you can build a practice on that. People can build a practice on convincing people that they're making a difference. It's just not going to be fulfilling for anyone. And ultimately, I bet there's just a hole in the boat, So if you grasp the principle, you don't have to memorize any techniques. the principal invents the techniques. And so you get to stay in this deep experience that's really whole and fulfilling, like kind of like anything you would do for fun that you would really deeply get into and not be distracted by a phone or something else, like that you would just think of like a surfer who wants to wake up in the morning and go surfing. It's hard work, but when they're riding that wave, it's so beautiful that all the hard work is like not hard work. It's just, it becomes associated with riding that wave. And that's a pretty good analogy. When you're following something to release, it's kind of like you're engaging and riding a wave to its completion.
I guess, sorry to say this is my final question maybe, but how do you know like what to do with your hands? Like there's sometimes where you're just like holding the ankles, or where you're actually like working your thumbs into the arms or anything. Like,
Yeah.
what's like, for lack of the better word, the thought process of like.
Yeah. That's interesting. Is there like a little key, like here is the phrase that will encapsulate it, like you go here when? So it's about sequencing, really, is what you're talking about. And sequencing, you have to have clear perception. You have to be able to go into neutral, be able to feel ease, and then the thing that needs to be treated will get a hold of you. Whatever's on surface, that will draw your attention. So I use the analogy of if you're in a mountain valley and you're sitting and you're enjoying the scenery, well, if no animals move through there, your attention will likely be very diffuse. You'll just be taking in the whole thing. And, the wind goes through and you'll sort of see the wind through how it moves everything. That's kind of like these inherent motions that when you're starting to listen, that's what you're sort of looking for. You're looking for the footprint of the health as these inherent motions, like the cranial rhythmic impulse, or we call it the tide in biodynamics of osteopathy in the cranial field. And then there's the long tide. So there are these like natural things that will grab your attention, but not really focus it into a spot. They'll grab your attention, but they'll show you bigger patterns. Like they'll show you integration, and that's health. And the lesion will pull you in. The thing that needs to be treated will pull you in. And if you focus back out to look at the whole thing, it'll pull you back in. So that's how you know where to go and what to treat. So if you're starting listening at a handhold where you can't really fully interact with what's pulling you in, then you just physically let it pull you in. You go over there and you just try to find, how do I relate to this thing? Again, if you get too technical with, I need to memorize this hand position for this lesion, if you know the anatomy, that's your grounding. Because then when the lesion presents itself, you automatically interpret the lesion with respect to its anatomy without thinking about it. It's just like your subconscious processing uses all of that knowledge and presents it to you consciously. So you're like, oh, this is involving like the transverse processes of the lumbar spine, and the quadratus lumborum is in this, and something's going on in the region of the QL ligament. The erector spinae are a little bit more active. Like that's what this lesion feels like. Let me go there and get a handle on, well, it's the QL, so I maybe get a handle like where ribs 11 and 12 meet thoracic segments 11 and 12. And then maybe either somewhere on the innominate, on the pelvis, or maybe on the front, on the side of the pelvis, hold it. Or if it's a rotational thing, maybe I can be on the abdomen and rotate it. So you have to begin to dialogue with the lesion, not necessarily even dialogue. Like you don't have to motion test it. You can just get there, find a contact, and listen from stillness. And if you watch how the inherent motion moves through it, then you'll see its ease. And just, do I have a handhold that I can engage this ease, that I can follow this ease? And if you don't, well, you move your hands until where you can. So that little bit of anatomy, right, that expands out into a huge thing. So like I said, you don't have to like do a lot of thinking for this, but the groundwork for the patient's health, to use you, to be like good, and not for it to be a bunch of effort for you to be a tool for this process, you got to know anatomy. And back in the day, you couldn't learn any manual medicine until you had passed anatomy with 90% accuracy. You wouldn't be admitted to what we called, in old osteopathy, they call it the operating room.